Thank you very much, Dr. Azra. Um, just for the past 2 days, all we've been hearing is hybrid imaging. So the hybrid imaging indeed is taking over. And one day, due to redundancies and the fact that nobody will be making a non-hybrid imaging cameras, we'll all be doing everything on a hybrid imaging camera. So right now we need to find the new indications that are there. So with PET, every day we're finding new indications for its usage in oncology. Similarly for SPECT CT, because it's a new technology, every day we are discovering what we can do with it better than what we were able to do with the previous non-hybrid imaging technologies. So one of the fields that one of the fields that the hybrid imaging or SPECT CT can help is the I-131 imaging. Why? Because I-131 has high energy gamma emissions, and it doesn't give you very good sharp images. So adding CT to it does help in a fair bit, especially in when we're trying to stage the disease, follow up recurrences, and so on and so forth. So first, just a slide to say what's the scale of the problem. We are an iodine deficient country, high incidence of goiters, solitary nodules, cancers. 80 guidelines, the latest ones, very controversial. However, that's the best that we have at this point in time. What does it say about surgeries? It says more than 4 centimeter do near total thyroidectomy followed by radioactive iodine. Less than 1 centimeter, just go with lobectomy, no radioactive iodine. But it's the middle part where there's a bit of a problem, where if it is between 1 and 4 centimeters, when do we go for near total, when do we do lobectomy, and when do we give radioactive iodine? And this is where SPECT CT can actually help us a lot. Excuse me. When we search the latest literature that has been published, it says that we can use SPECT CT in differentiated thyroid cancers in localization of nodules, pre-treatment planning, post-treatment assessment, lymph node evaluation, which is very important, evaluation of distant metastasis, because we can sometimes have physiological uptake, and it's really hard to differentiate between the two. We can measure the response to treatment, and we can do recurrence assessment, and I'll show a few images in regards to most of these things. Post-surgically, we do frequently do a low dose iodine 131 image, and SPECT CT for that imaging can help us a lot. Why? It can be useful for the assessment of residual thyroid in the thyroid bed and the completion of staging by visualization of lymph nodes in any, or detection of presence of distant metastasis and its differentiation from physiological excretion. So that place between 1 and 4 centimeters, you want to know whether it's high risk or not. You want to go for total thyroidectomy and then radioactive iodine or not, and then it can lead to accurate therapeutic dose planning. Yesterday we heard a lecture where they said that to a child with large disease, they had given a low dose of 66 mCi, and that child is still having a bit of a problem. So looking at a typical case, this is a patient with 62-year-old female with papillary carcinoma, follicular variant, total thyroidectomy, no lymph nodes were involved, whole body scan was performed under hormonal withdrawal. And we can see that there are 3 areas of uptake that we can see. There is a very subtle focus in the middle. Let me see if I can point the laser pointer to it. So what is this? Is this just something that we are seeing? Very low uptake. Does it have any significance? And so in this patient, a SPECT CT was performed, and we can see that it is a mediastinal lymph node. So it's not just something in the esophagus. It is actually a lymph node. So again, state changes, treatment changes, prognosis changes, so on and so forth. Another patient, 37-year-old female, CA thyroid, very low level of thyroglobulin, but very high anti-thyroglobulin antibodies. So not an ideal situation. We need to do some imaging. So imaging was performed, and if you look at the planar image, we can see that there are 3 foci, 1, 2, and 3. This is somewhere in the face, so probably not very malignant, but still we need to have a look in the neck and then lower down. So first, the top activity, SPECT CT was performed, and it's in the nasolacrimal duct. So it's just a normal physiological finding. It's not metastasis. The second one, tip of the hyoid bone, and at the tip of the hyoid bone this was a remnant of the duct remnant, the thyroglossal cyst remnant. So again, physiological, not metastasis. However, when a SPECT CT of this last one was done, it is a lymph node. So it's a remnant, sorry. You can see the clips down there. Surgical clips, this is just a remnant. So no distant metastasis. So without the help of SPECT CT, we would have been in a bind whether this is metastatic disease or not. But with the help of SPECT CT, now we can say no, there is no distant metastasis. Patient is relatively safe and downstaged. Similarly, another similar patient, 36-year-old female, multifocal papillary thyroid cancer, thyroglobulin very low, but anti-thyroglobulin antibodies quite high, so not very reliable. Two foci when it comes to the uptake. SPECT CT is performed, and as you can see, with this here, these are the surgical clips. So this is probably a part of the remnant. However, this uptake is in the lymph nodes. So the stage changes, treatment changes, dose changes. Young child, 14-year-old girl, post-thyroidectomy treatment, 1 MCI scan was done, and you can see there is a lot of uptake. And where is that uptake? It's in the lymph nodes. So we can see it's in the lymph nodes. Bulky disease, resurgery is needed. Patient cannot proceed without resurgery, and till then, any amount of radioactive iodine will not help the patient. Again, a diagnostic scan for a 37-year-old female after total thyroidectomy. Want to see a lot of uptake. Is it just the thyroid bed or is lymph node involved? And if we look at the lower panel, we can see that there is some lymph node involvement. In the post-therapeutic RI whole body imaging, when we've given a rather large dose, how can SPECT CT help us? We can do whole body scan using, it can do the completion of staging, it can do risk stratification, assessment of residual disease, and for future therapeutic planning. Again, a patient in which radioactive iodine has been given, 3.86 gigabecquerel, and if we look at the SPECT CT, we can see that it is a lymph node. So here it just looks like the bed, but when SPECT CT is performed, we can actually see a lymph nodes involved, state changes. I should be able to wrap it up within the next 2 minutes. Similarly, this is a patient in which rib resection, rib mass was seen, rib resection was done, turned out to be thyroid cancer, underwent total thyroidectomy, and a large dose was delivered. And when the scan was performed, we can see uptake in the abdomen and in the shoulder. The shoulder uptake turns out to be in the scapula, if you look here, and then abdominal also uptake is also deposits of CA thyroid, and now needs a much larger dose when it comes to further treatment. Again, a patient in which radioactive iodine is given, no focus in the neck as such, nothing in the chest. However, when SPECT CT was performed, it found out that rather large lymph nodes which are non-iodine avid are there, and now this patient probably needs to undergo PET scan and then TKIs and so on and so forth. In the normal follow-up protocol for us when it comes to CA thyroid is we do serum thyroglobulin and anti-thyroglobulin antibodies, and thyroglobulin measurement can be affected by the presence of anti-thyroglobulin antibodies and cause inaccurate results, and then we have to do whole body iodine scans. So in this patient, 47-year-old female, high thyroglobulin levels 11 years after successful treatment with total thyroidectomy and radioactive iodine. Whole body scan has been performed, and it turns out that there is a lymph node there, and then this patient now has recurrent disease and then now needs more radioactive iodine and treatment, so on and so forth. So thank you very much. If there are any questions, I'll be more than happy to answer them. Yes, you're right. Because of the fact that radioactive iodine has some gamma radiation that's very high, uh, probably even the heaviest collimator will not be able to help us. But because of the fact that we get good localization, it's not improving the resolution of the iodine part of it. It's what it is doing is giving us better localization with the CT, and that tends to help with the up or down staging. So per se, at this point in time, I don't think there's very many things that can be done to improve the resolution of the iodine scan. But with the localization, we can maybe get better results that way. Right. Thank you very much.